Hello, everyone, and welcome to this all-important session on using COVID-19 therapies to help the most vulnerable. My name is Nicolette Louissaint. I serve as the Executive Director of Healthcare Ready. It is my pleasure to be with you all this afternoon. Really glad that we are able to take this hour and have a conversation about how we can use COVID-19 therapeutics, recognizing that there's tremendous opportunity as the pandemic is still not behind us to make sure that we are doing everything we can to ensure that individuals who have been recently infected with COVID-19 and recently tested positive have access to the therapeutics that can have a tremendous impact on their health outcomes. And so as we are going to use this next hour, we would like to first reflect on past opportunities or missed opportunities, but also focus on solutions for the next phase of this pandemic. As the vaccination rollout continues, there's a need to both balance how we are pushing out vaccine, but also recognizing that not everyone has been vaccinated. And there are a number of counties across the United States where there is a continued increase of COVID-19 cases, and we have to do the work of increasing the availability of those therapeutics to those hardest hit communities. One could look no further than the current impact of COVID on the state of Michigan to understand the work that we have ahead of us. So I'm very pleased to be joined with two experts who've been diligently working on COVID-19 and very, very aware of the opportunities we have to make sure that we can really help vulnerable communities with increased access to these therapeutics. Joining the panel discussion today, we will also have a demo from one of NMQF's own, Mr. Taylor Stair. So I'm first going to read their bios and introduce them, and then I will turn to Taylor for the demo. First, we have Maya Bermingham, who joined Regeneron in 2015 and serves as the Senior Vice President of Public Policy and Government Affairs. Ms. Bermingham and her Washington, D.C.-based team play a critical role in helping Regeneron shape and maintain its industry-leading reputation among governmental stakeholders. Prior to joining Regeneron, Ms. Bermingham held roles increasing responsibility at pharma over her 12-year tenure, following earlier positions at legal firms and work for Senator Moynihan and the Senate Finance Committee. She is a graduate of Harvard University and the New York University Law School. Dr. Gary Wiltz is a board-certified internist who has been employed with the Teche Action Center for over 30 years, serving as medical director from 1982 to 2002. In 2003, he was named CEO of the organization and serves in that capacity to date. He's a graduate of Tulane Medical School, and he has served on many local, state, and national healthcare committees, including 2 governor's healthcare reform projects. He is the LCPA clinical director, secretary, treasurer, and most recently has served as the chair-elect of the National Association of Community Health Centers. Taylor Stair is a data analyst at the National Minority Equality Forum, who joined in fall of 2019 and has been working with Dr. Puckering and Mary Murray in developing NMQF's various indices since joining. With the onset of COVID-19, Taylor has been managing the back-end data being generated by the MRCIS COVID study, which is being conducted with FQHCs across the United States. Throughout this study, they've been enrolling individuals and having them receive COVID tests. Mr. Stair is now involved in creating the COVID Index, which he will share with us today. Taylor, over to you.
All right, thank you very much, and thanks for the introduction. So I want to go ahead and turn off my video and share my screen so that we can see the index. So let me do that real quick. Okay. So this is the index, and you're seeing that now? Excellent. Okay, so this is the COVID Index, and so we wanted to show this off a little bit. This is a tool that we've been working on, and this is very much an iterative process. So there's still development work being done on this, but wanted to go ahead and share this with everyone. So this is actually a publicly available index. Sorry, this is actually a publicly available index. And so to access this index, all you actually need right here is the covid.nmqf.us So if you put that in your search bar, you can go to this index and use it. You do not need any credentials to use the index. But here we're mapping COVID cases across the country by zip code. The data set being used for this index is the Johns Hopkins University data set. And so one thing that's a little unique about this index is I've seen, there's many mapping tools out there for COVID. And one thing that's a little unique with this is that we do have zip code in the index that we're using. So I can scroll over a single geography here and we will get some quick summary statistics on that geography. So here we're seeing particular geography in Illinois. So we have the population, and then we're seeing cases per 1,000 people is the statistic that we're using here. So right away, you can see that there's several hotspots that stand out, and Michigan in particular has been in the news as of late. If we are to select a single geography, we're actually given a graph here that gives us the trend for that geography. So again, this is a zip code. And so we can see the cases per 1,000 in this geography over time. And then another thing that's fairly unique about this index is that in addition to the historical data going back to January 31st here, 2021, we're actually making an effort to project 4 weeks into the future on what we think will happen in all of these geographies across the country in the next 4 weeks. And so we've actually worked with a statistician named Peter Congdon, who is out of Queen Mary University of London, and he uses Bayesian modeling for those projections. So these are projections that we are continuing to tweak and trying to improve. As you can imagine, trying to project this into the future is, obviously somewhat fraught activity. We often compare it to trying to predict the weather, but we think it's an important activity nonetheless. So I want to go ahead and so we can change our map here. So we can actually go back in time and see COVID-19 as it manifests across the country, in this case in August, or we can project forward. May 23rd is as far forward as we can go. And this is how that appears looking into the future. So we can make those adjustments. We do have a couple of different filters that can be used. So in addition to cases per 1,000, we can do just 7-day running totals for cases. And then the same thing for deaths is also available here. And then another feature I'd like to go ahead and point out that I find helpful is we've got these data layers. And so we can lay over top of our currently aggregated data these other geographies. So we have a lot of partners that work in the legislative space. So I'm going to go ahead and turn on our congressional district overlay here. And so if we zoom into the map now, we're still seeing COVID cases by zip code, but now we've got congressional districts laid on top. So now we're seeing Illinois 2 is showing up here. And if I now click on this geography, we're seeing the zip code with those projections, in addition to seeing the historical data for the congressional district and the projections for the congressional district. So that is a feature that can be used with any of these geographies, any combination where you're aggregating here by whichever geography is chosen. We can also use the overlays as well. And then finally, another feature I'd like to point out is that we do have a top 25 ranking of geographies. So right now we're aggregating by zip code, and so we're ranking zip codes. And we can see that Michigan does indeed fill out pretty much the entire list as we're seeing it now, but then we can go ahead and change. So let's use our MSA geography, and I'm going to turn this off really quick, and we can see how that changes our results here. So now we are seeing MSAs ranked top 25. And then one final thing that we can do with this tool is if we go into the filter, if we go to the geography section, we can actually set a bottom limitation on population. So basically any MSA where there's at least 1.9 million people would now be mapped. And so this is a little bulky on the filter here. So I think we're actually One of the things that we'll be changing is making this a little bit more granular for the adjustment, but I can now apply that. And so what we're basically left with are major metropolitan areas. And so you can see how that changes our ranking. So this top 25 ranking will be dynamic, and it will react to whatever geography we're using. And then also between our statistics, or if we've got a population filter in place. So these are kind of the basics of the COVID index. And so we definitely hope that people will go to the index, and again, covid.nmqf.us to access the index. And so we certainly hope people take advantage of that, and certainly love any feedback as we continue to develop the index.
Thank you so much, Taylor, for that overview, and the URL is in the chat. Very much appreciate you taking the time to walk us through that. And so with that, I'm going to turn to our panelists. And I would actually love to start with Dr. Wiltz and asking you to share a little bit about your patient's experience with COVID, especially early on in the pandemic. Dr. Wiltz?
Hi, well, thank you for having me, and good afternoon, everyone. Let me just correct my bio. I served as chair of NAC. I'm not the chair-elect. I'm sure it will make the current chair-elect a little bit nervous thinking I'm coming back. But it was a great honor and opportunity to serve in that capacity. That most valuable tool that we call the retrospectoscope would be what I'm going to talk about. Looking back, you know, there's so many things that we would have done differently in hindsight. Unfortunately, it is what it is. And but looking back during the height of when we had the most infection going on, when monoclonal antibodies, when it became apparent that they were effective, we missed an opportunity, I think, to make that publicly known. And I don't think it was done in a sinister sort of fashion. I think it was done unintentionally, maybe, but not as much, well, not as intentionally as I think we could have been and should be and are going to be now. You know, that expression about don't ask, don't tell. Well, if you didn't ask, then you weren't told about monoclonal antibodies. So early on, we had a lot of our patients that were presenting, not so much in our center in the FQHC world, where we would, well, first of all, you know, our testing was a mess in the very beginning. It was like who to test. We didn't have enough tests. Were the tests accurate? So that was a lot of confusion. And then we started prioritizing. But as we moved into people going into, particularly in the emergency room, is where we found there were problems where, and this was a bias that we saw, particularly in the minority community. A lot of people were presenting very, very ill to the emergency room and not being admitted or not being treated aggressively and being discharged and asked to monitor themselves. By monitoring themselves, I mean, some people, there was a shortage of thermometers in the beginning. There was a shortage of pulse ox for those that were trying to measure their oxygen levels at home. And so there were a whole lot of people that I think could have gotten treated much more aggressively. Even being put on oxygen at home and steroids and inhalers and things that could have been done that got missed. What was concerning to me was when monoclonal antibodies did become available. And I forgot what action alert I received about it finally had gotten approved. So I called the local hospital and found that they had received it a week prior to my calling, but they didn't know how they were going to set it up. And this is all the while where people were still getting infected. And so I know for a fact that I have several patients that there's no doubt in my mind that could have benefited from receiving the infusion, that could have prevented hospitalization, and in some cases could have prevented death. As I said, it's unfortunate that that happened. I shared with you know, Dr. Bermingham that I participate on the Governor's Health Equity Task Force, the National SEAL team, which is the Community Engagement Alliance. And we've had all these very, very aggressive outreach marketing campaigns communication campaigns on getting people tested and vaccinated, but we didn't use as much energy, I feel, to leverage that resource to let people know about the monoclonal antibody infusions. I don't know how many of you read, there was an article last week in USA Today that is talking about Regeneron. I think they're one of the sponsors for this session, that they are now getting infusions. They're making them available in a home setting. They're making them available for injections rather than an infusion. Community health centers have now been put in the queue that if we could get the resources, we can actually do the infusions in our centers now. So it's ramped up tremendously, but we missed, I saw one quote, and not any slight to Taylor there, but one of the people said that you don't need a statistician to tell you that it works. I mean, after the infusion, the next day, patients were texting me, and I saw one person said it was like somebody giving them a happy pill. Within 24 hours, that they made that much of a difference. And so we can't go back, but I think it's a lesson learned. And, you know, as we can't get so focused on testing and just the vaccines, that there was an intermediate step that can still, at the moment we're speaking, could have and still can save lives.
Thank you so much for that overview. And I was sitting here scribbling a few things. I definitely plan to ask a few follow-up questions, but I'd first love to turn to Maya Bermingham. And as we're talking about COVID-19 therapeutics, we really are going to be honing in on the opportunity presented by monoclonal antibodies. So could I turn to you to ask that you share an overview of how the monoclonal antibodies work, as well, knowing that Regeneron has really been leading the way on the monoclonal antibody therapeutics. Could you talk a little bit about your trials and the process of ensuring that you all had diverse clinical trials to understand how they would perform in these populations?
Sure. So thank you to NMQF for providing this really important opportunity. You know, I always start out with the simple message, which is, you know, educate, diagnose, prescribe, and treat, whether it's vaccine, whether it's a monoclonal antibody. You know, I have been fortunate and unfortunate enough to have lived, you know, both the promise of monoclonal antibodies, as well as the you know, the holes and the fissures that we have lived through during COVID that have really you know, heightened some of the lack of education and the lack of access. Let me talk a little bit, just to take a step back, about monoclonal antibodies. And again, speaking from a layperson's perspective, you know, for many, I think the idea or the terminology can be very daunting in terms of what a monoclonal antibody treatment is. But quite simply, for those of us who are not all steeped in the science, a monoclonal antibody, and in our case, it's a cocktail. So there are two antibodies that are basically intended to act as your defense to a virus. And in this case, one hopes that a patient who is infected with COVID would be able to mount their own antibody response. But in some cases, for whatever reason, there are certain patients who are more vulnerable, those who have certain conditions, who are obese, diabetes, kidney. There are a host of other conditions that can frankly make your immune system less likely to react when you are infected with COVID. And so in essence, what our treatment and what monoclonal antibodies are intended to do is to substitute or to amplify your body's immune response. So basically, a monoclonal antibody is something that the body, through either an injection or an infusion, receives in order to fight the virus. And so quite simply, what you're doing there, whereas a vaccine is intended to stimulate your own body's immune response, in this case, if you are not vaccinated or otherwise immunocompromised, the antibodies are intended to augment your body's ability to fight off the virus. And with respect to Nicolette, I think one of your questions was about clinical trial diversity. So one of the things that has been remarkable and quite, it's both fortunate and unfortunate, is that COVID has frankly hit communities of color and other underrepresented groups quite hard. And in our efforts with our clinical trials, which focus not only on those who are infected, but also those who have not been infected but have been exposed, and in some cases for hospitalized patients as well, we actually were able to capture and again, sadly enough, those who were affected entered into our clinical trials. And so in fact, we had quite a bit of clinical trial diversity in our clinical trials. 40% were of Hispanic descent or African American. And so what we've seen has been a very robust representation of those who are most vulnerable right now in our clinical trials. So I hope that answers your question. Please always feel free to answer or ask additional questions if I haven't hit the topics.
No, that is very helpful, and that statistic is tremendous. And I think as we're continuing to think about those communities that have been hardest hit, it's important to know that the trials were done specifically understanding how the monoclonals would perform in those individuals, so that we do have confidence that they are going to be successful. Taylor, I want to pull you in very quickly because you had a few questions that came in, and I think based on the questions that are coming in, I think people are looking at this from the vantage point of understanding how to predict where there may be communities that could be hit hard in the weeks to come. And so I'm going to try to mash up a couple of these questions into one question for you, which is how reliable is the data in the index, and how do you plan on sharing the predictive data with other jurisdictions across the nation for them to use in their understanding to date?
Sure, yeah. So I think, as I said, the data itself is coming from Johns Hopkins University, and so this is the same data that's being reported out to everyone else. So that data, is fine. On the projections, now obviously that's where you're going to question the validity and want to know, how accurate are these predictions. Unfortunately, the index is relatively new, and so we don't have a lot of historical projections from the index yet that we can go back on and show how accurate those are. So that's something that we will continue to develop.
Thank you. So now I want to turn to Dr. Wiltz for a second and get a lens into how you mentioned that you had to make a number of phone calls to figure out which hospitals had monoclonals, and when you did make those calls, you found out they had them for over a week, and a lot of patients had to ask about access to the therapeutics in order to know that they were available. So I'd like for you to share with us how you worked to ensure that your patients had access to the monoclonals as they became available, and as you learned that local critical access hospitals and others had access to them.
Well, once again, I don't want to dwell too much on the past, but I think part of the misstep was that we didn't have a national strategy. I'll just be frank, and some of the language that was used was Dr. Bermingham said earlier about, the connotation of clinical trials and what that means. When the whole Operation Warp Speed was named Warped, that has a whole different connotation to some of our people. Warp means it's broken, it's all bent, it's out of shape. They didn't think warp speed, Star Trek sort of like high speed. When something was warped, that means it was deformed and rushed. And so that was a lot of cynicism in the beginning, having to explain to people the clinical trials for the vaccines as well as for the monoclonal antibodies. I know one of the most effective tools that I used was I had a poster up in every exam room of Dr. Kizzy Corbett, particularly show the African-American community the lead scientist that Dr. Fauci had referenced was an African-American female physician that had been working on this for years. So it wasn't like this was something that just popped up. Same is true for the work that's being done, that was done on monoclonal antibodies. So once we found out, I'll give the state credit. Actually, if you go back, you know, when Trump became infected, he got the monoclonal antibodies and gave testimonial, but it never was put out there in a way that I think that could have really got a lot more bang for the buck, if you will, because he and everyone that every patient I've got, I say it's been so dramatic. But what we did was the state, the Louisiana Department of Health and Hospitals, made a master list of where all the centers that received the monoclonal antibodies, and that was another big question. I saw it was a question in the chat, in the Q&A. Is it free? Is it billed? Yeah, it was free. It was made free and available to everyone that qualified. And the criteria, unfortunately, you know, one of the criteria, of course, is 65 and over and having comorbid disease. Louisiana, probably about 90% qualified just on BMI alone. Unfortunately, we are near the top in that list, one that we don't want to be. But if you look at the comorbidities, so we listed all on the website where the nearest centers were. Then we started posting it in the exam rooms. They started posting it in the emergency rooms, and then we just used social media for good, rather than all this misinformation was out there, and got with the faith leaders in the community, the elected officials, and just every opportunity that we had, we got the word out, you know, and it really did make a difference, because it was like, and I had a lot of professional colleagues. I sit on a lot of boards, and I remember having conversations with some of the trustees of some of the other institutions I sit on. And when I kept talking about the monoclonal antibodies, they didn't know. And that was striking to me, that we just had something that was so great, so rich, so meaningful, impactful, and we just didn't. But as I said, I think those now we are learning, and we have a national strategy. I think the Biden administration is committed. I think they just bought, I think from that article, you know, they've made a purchase of a whole lot more of monoclonal antibodies, and they're going to be actually making a very aggressive outreach campaign to make sure people know, not only get tested, but if you're infected, every hour counts. If we can get folks in, you know, as early as we can, it's just like, you know, someone comes with a stroke. If we can get them in early, then we can prevent all this heartbreak that we've been experiencing. So that's kind of what we're doing right now, and what we did then.
Thank you for that. And as you know, as you're talking, I'm hearing opportunities. And Maya, I know you and your team have been working very hard to make sure that there is information being shared about the monoclonals, how they work, how to access them, and finding solutions. But, you know, Dr. Wiltz, your point, I think we can't divorce where we are now from where we were, because a lot of this is building on the first phase of the response. And so trying to do a lot of that direct work to individual jurisdictions and states, I know it's been a big part of what Regeneron and your team have been up to. Could you shed some light on how you have been conducting education and outreach across the nation?
Sure. So let me start with, you know, just a reality, right? So COVID probably amplified some of the disparities that we have in our healthcare system, as well as just basic communication, right? You know, I know from the beginning, there are dedicated government officials who have been working on this, who are agnostic, you know, to who you are, what your, you know, what your political affiliation is. We're all in this really to ensure that, you know, the science as it was evolving we had to problem solve, right? And a lot of that has to do with communication and education. And certainly the government themselves have been trying to get the word out together with a number of different stakeholders who have been working with the, on the index through CDC to find out, where are the infections, right? To Dr. Wiltz's point, for a while, you didn't know, who had COVID, who didn't. Upon diagnosis, it's almost too late sometimes. If you're a patient who is diagnosed, you need to know about these education, these possibilities beforehand. Reaching out to physicians in areas. Taylor put up the what we call, the hotspots, but really trying to target our education through social media, through communication paths, the television, through faith-based leaders, through community leaders. And that takes time and effort. And frankly, it's a constant evolving effort to make sure that you can really reach out to people and meet them where they are. And COVID has scrambled us, right? I mean, quite frankly, all of us are, hiding, in our houses, behind plexiglass, whatever methods of communication that were traditional, we've had to look at those and less traditional. And so what we've tried to do together with the team, from our scientists on to folks who work constantly on market access, on geographic access, on communications, is really try to highlight for patients and physicians, first of all, the availability of a treatment, the necessity of treating early, right? So for treatment, it's very important that you get treated within a certain amount of days upon diagnosis. And so what we've tried to do, working with a number of different partners, as well as the government and those the government has designated as reaching out to underrepresented groups, is to really make ourselves, I mean, it's almost like each solution, you apply it and then you have to adapt to the different circumstances. If you've seen one person, you've seen one person. Dr. Wiltz can speak to this. He's closer to the ground, but I know from personal experience and, coming from a family of physicians, it takes a lot. There are people who already know about this. When you get COVID, you're tired. You really need to have an army of advocates for you to pick up the phone and say, okay, you got tested. Here's what's available to you. Should you fit the criteria? Here's how we're going to get you to the doctor. Here's how we're going to get you to a site. We have worked with several partners, including the government. We've worked with national infusion centers. We've worked with hospitals, because you have to match it, right? You have to meet the patient where they are, try to get them to a site, get a physician who actually understands. To Dr. Wiltz's point, is, some of this information was coming out as the clinical trials were evolving. And so that's been a tremendous, I know from my family members who are physicians, it really was you need to look at the data, you need to feel comfortable, you need to have confidence. Then you have to actually get to the patient and help them where they are in their community, where frankly they're isolated and they're infected. So that's a whole other thing.
And
We
to
had
that
that
question,
conversation. We had that conversation earlier, particularly in rural communities. You would ask folks to go home and socially distant. You're talking about a family of 12 living in a one-bedroom house. There's just no way that can happen. But one of the things, strategy-wise, it's a simple thing, but I think everyone that's been allotted the infusions, the monoclonal antibodies, if you present to that institution, an urgent care or a hospital, when you're seen and evaluated and then you're diagnosed and you're positive, every patient is given discharge instructions. It would be very simple in the discharge instructions to say, you've been diagnosed with COVID and you may be eligible for these monoclonal antibodies if you have these criteria and these symptoms within 72 hours. That was never done with the patients that I saw, that when I got the record that they had not come to us, but gone to an urgent care or emergency room, and then I had to contact them. But if they were given that information on the front end at the time of diagnosis, then they would know. As was said, now you know. So then, of course, it's the logistics of getting and writing the orders. I have a colleague that's a hospitalist that does our inpatient for us now, that I don't do that anymore. But it's just something as simple as that. Everyone's given discharge instructions. You know, we have EMTALA laws where you have to treat everyone that walks in the emergency room. You know, and then, so I think that's a simple thing that can be looked at.
Definitely. I know there's been a lot of effort to put every solution that can be brought to bear up. So I think that's definitely something that can be explored. I want to touch on that cost and availability question, because I think that's something else that lingers. And I think that's another one of those lingering impacts from the earlier phases of the response. I think providers, we've heard expression from providers that they're hesitant to offer solutions or offer a path to a therapeutic that may not be there, or a patient may not be able to afford. So could you two just speak to the cost of the monoclonal antibody treatment, as well as the availability of the products across the nation?
So I can take part of that, and I think Dr. Wiltz will be far more adept at answering some of the practicalities of it. But what I will say is it may not be well known that the therapy itself is free to all patients. The services that are associated with the delivery of the monoclonal antibodies are often covered in some instances by either Medicare, depending on if you are a Medicare patient. There are, in many cases, if there's commercial insurance, many, and we wish more, commercial insurers have made it clear that they will waive copay. And then there are efforts underway to ensure that there is robust reimbursement, because as you can imagine, infusions require medically trained professional. And certainly, whereas it may be less complicated to administer a vaccine, but the infusion itself requires a medically trained professional, but should not be complicated, quite frankly. With robust reimbursement, these are things that are, these are infusions that are provided to cancer patients and many other kinds of patients. And so the trick is getting it all right, getting the patient educated, the physician educated, getting the patient to a site. And you mentioned the supply. There is ample supply. The issue really now is, frankly, really hitting at all cylinders the patient journey, and making sure that the patient has a site that is accessible. And many of us are working very hard to meet patients where they are, because we know how difficult, even under the best of circumstances, it can be, when you're not tired, when you're, not isolated, to find a site that can administer. And so the government, several stakeholders, I know the FQHCs, we're all working very hard at solutions. And Dr. Wiltz mentioned as well, home infusion is also an option that we are really trying to ensure is available for those patients who can't otherwise reach a site.
A critical component of our team is the patient navigators and the community health workers. I think all of us that work in FQHCs, if we don't have a formal degree, we have a street degree in social work, because that's a large part of what we have to do and help patients navigate. When they present themselves, I always tell my providers, it's not if you're going to treat them, but how you're going to process and get them through the maze sometimes. But that's invaluable. Find them, locate them, make the logistics. We have a robust referral department that takes into consideration transportation and all the other social determinants of how we can get them there. And we have not had an issue with getting the infusions. And it's just like the vaccines, there's a allowable administration fee for administering, but the vaccines are free, just like the infusions are free. And we have not encountered that as a barrier so far. We're blessed to win a Medicaid expansion state, and the governor has been, and I publicly said it, and I'll say it again. For the vaccine rollout, the governor was very intentional in stating that he wanted the elderly and the African American population and the most vulnerable population to be at the front of the line. And in the salesmanship of trying to get people to take the vaccine, I've had to tell folks that it's one of the few times in American history that minority groups have been placed at the front of the line to get the benefits of therapeutics. And it's up to to us to convince people to take advantage of that opportunity.
Nicolette, I wanted to mention something that I think Dr. Wiltz really hit the nail on the head. The question isn't if, it's how, right? And I think we all have to take that responsibility. I know for myself, I've dealt with, people who are tired, they want to crawl back in bed, they start to feel better, and then their situation really turns to the worst. And I've had some heartbreaking stories, and I've had some really good ones that, have ended up with literally like one person who, a day later was mowing the lawn and, had to call the spouse and say, are you sure this person should be mowing the lawn? And I've also had those heartbreaking stories where, you have advocates who are just, the answer can't be no for those who are appropriately prescribed, right? And I think we all have that responsibility as, fellow human beings to really think through, what is it from the patient's perspective that they need, and to just keep knocking on that door. I've had to do it. I called myself personally for people where I just said, here's your testing center, here's a site, and I've tried to do it for the calls that I've received. And I know, so many of our teams have been dedicated to doing that. You can only get to so many people, and the hope is that, it really will take a village. But, I wanted to just highlight what Dr. Wiltz said, which is it's not, will you, it's how. And that's a really important, problem solving approach to take.
No, I totally agree with that. And I'm really glad that you highlighted that, because as you two were speaking, I've found that a lot of our questions and hesitations, is there enough product? Is there a way to make sure that patients are aware? There are a lot of things that, is there a cost? A lot of those initial concerns have been alleviated by the measures that have been taken, but the question becomes, how do we make sure that every step of the pipeline, whether it's at the systems level, and Dr. Wiltz, I love your comment about the discharge papers. I want to spend some time thinking about other things that are systems wide that we could begin to implement, because as we've talked about, it'll be a 50-state solution. So we'll have to work with every state to be able to do this. But that's one piece of it. How do we make sure this easier on providers? We talk about the impact of COVID on the last year on us as society, but no single profession has been more impacted by this pandemic than providers. So how do we make it easy for them? How are we making sure that how is translated to them in a way that doesn't also translate to added burden? And then how do we do the same thing for patients? And you both have pointed out one very important component of this. Once someone is COVID-19 positive, they're also very fatigued. So you're also dealing with someone who either in that midst of fatigue has to advocate for themselves, or has a loved one who in the midst of their own fear and concern for their loved one has to advocate for them. So I see it as a number of steps along the way, but I want to start with the systems level. If we are looking at solutions, and Maya's heard me say this a few times, in some ways on the disaster side, it's a 50-state whack-a-mole, which means that if you do it once, you got to do it 49 other times for it to actually roll out across the nation. So how do we start with a systems level approach to actually looking at what could be done and implemented across the nation to address that how?
Dr. Wiltz, I will let you go first, since I've been going first, and then I will comment as well.
There's a line from the movie Shrek when he says, "That's the story of my life." That's like I've been harping on this for 40 years of having a state strategy. I mean, having a national strategy, then a state strategy, because without the backstop of the federal government, civil rights have never been implemented. If you have to have a national leadership strategy, I know early on in the pandemic, when then the state strategy, the governor made the decision to shut down all the schools. It wasn't going to be 64 counties independently saying, each one are going to do this. He shut it all down, and so having that uniformity and consistency, I think, made a big difference because it was a policy that got implemented, on that level. Local, knowing the local, I have the most respect for the, local folks, local elected officials, because I was actually had the honor of being a county commissioner at one point in my career, and people know where you live, they know where you worship, they know how to put their hands on you. So, that granularity is something that I think at the end of the day, we had I'll just give you an example. We had a big surge for the vaccinations. Now we're getting more granular. We call it guerrilla warfare. And I'm sure you all have heard that the Biden administration is now making monies available in the Labor Department to hire canvassers to go door to door. It's almost like the census. Now we're going door to door to try to get people. I was on a call the other day, and patients, and then these are the conversations I have with my patients. It's not only the medical side, but as both of you said, it's the cost. So someone heard, but it's never been put out on how to access it, that FEMA will reimburse for funeral expenses. So on that call, we actually had someone that posted and put the whole information on how they could go even apply for this. And it's been out for a few weeks now, but it's just those simple little things that people, I kind of heard about monoclonal antibodies, but they don't know how to go about doing it. And so, and it shouldn't be the advocacy where we have to one-on-one do it. We've got to figure out a way. So to answer your question, Nicolette, there has to be a national strategy. There has to be a state strategy. The way I've approached it is we deal with the community on the local level. We know our folks. That's all I can say is the community health center world. I know Pope Francis he made a statement that, I know my flock, they know my voice, but you got to even know how they smell. You got to get up close and personal to really know how to reach people that you're trying to reach. And so it's not so much a disconnect. I know Maya and I had the conversation earlier about, the national policy sometimes as well intended is how they implement it at the local level. And I think if you get that feedback, then we can be a really tremendous part of the process to help affect the change that I think the national policymakers are trying to do. I use the example, we get a lot of grants. We get a grant in FQHC world that comes to the local board of directors that's 51% consumers. One of our partner agencies is Community Action Head Start. They get a grant. The USDA gets, all these folks get grants that come from Washington down to the local level, but we don't always communicate amongst ourselves in a way that we should, that we can leverage and coordinate a lot better. So that's my soapbox, and I'll get off that.
And I think, Nicolette, to your point, Dr. Wiltz's point, so the national government can help with resourcing, with supply, right? They can help with education, but then it is up to the states to some extent to amplify, right, in terms of education. Giving, for example, the NIH just issued guidelines on monoclonal antibodies. I know for many physicians, right, that might have been a bit of a bar, because if you're not aware of the information that is out there and the clinical evidence that is really, the responsible way to go, which is to look at the clinical evidence and figure out what's right for your patient at the local level, you need to have that communication from a centralized place going all the way down to the physicians who are treating and to the patient. So that's number one, is just understanding, the tremendous evidence. In our case for REGEN-COV, right, our clinical studies, which take time, right? It's not like you just snap your fingers and the answer. We were able to reduce hospitalizations and progression of disease by 70 to 71% in the eligible populations. Until you hear that number, you may not understand what the promise may be. Then there's the question of tailoring. To Dr. Wiltz's point is, we may use information and vocabulary that may not resonate, right? And so you really have to think through that. Similarly, hearing from physicians from different sites of, here's the supply, where's the patient, how do you get it there, how do you pay for the services that are associated with either, an IV, and then hopefully at some point, Dr. Wiltz mentioned subcutaneous, right? A different kind of administration where a patient may be able to receive drug through a subcutaneous presentation as opposed to an IV. Well, all of those steps, all of those questions of, how do you get the patient through the system? How do you make sure that the prescribers are aware? How do you make sure that the patient and the prescriber know where to go? And then how do you pay for it? I think what we've found is, to your point about whack-a-mole, is we're starting to put together different situations based on, or different solutions based on the situation. It's always helpful to have a construct to start with, which is, here's the patient, here's the doctor, here's how we're going to pay for it, here's the supply, and matching all those things up at the local level, because that's where the patient is going to receive it. So in many ways, the government can help, but then you need local leaders, local people who are on the ground to really tailor the situation. Going back to the how, right, is, what works for one person, we hope you can take those lessons learned, but then you're going to have to tailor it to someone who may not be able to get out of bed, or someone who may have transportation, but, has to come in at 9 o'clock at night instead of 8 o'clock. So all of those things, I think, we're at heart scientists, but we have learned that, we have to make it accessible. And that's where we, are trying our very best. And so many of our teams and other stakeholders are working 24/7, trying to bridge that gap.
Thank you. And so I've been taking tons of notes, and the part that I continue to stare at is the vocabulary that resonates. And I love that analogy of CHCs, not just knowing their people, but knowing their smell. So going to use that going forward. So now thinking about the provider perspective here, and thinking about the providers that have been at the front lines working through COVID, and now are being put in this position where they may not be as resourced to have really adept navigators and social workers that are assisting. They may see a lot of places where patients may be eligible, but there aren't enough handoffs to allow for them to make the recommendation or make sure it's in the discharge papers, and trust that someone else will pick up the baton. How do we make it easier for them? What could we collectively, what can we push states to do to make it easier for those providers who may now be aware of the promise of these monoclonal antibodies, but may not have all of those resources accessible to make sure that they can make that recommendation and then move patients to the next support or next navigator?
Well, I can speak to, the navigators, and again, with the assumption that a lot of our information may be available online. It's also available through, there are a number of websites, combatcovid.org, Regeneron has resources as well. So to your point, I think some of it is trying to find whatever media you can to help prescribers and patients and sites link up. There are also a number of stakeholders, and the government has been working on a locator with respect to the sites. I can't speak as cogently to what does one do at the ground, because I know Dr. Wiltz and others probably have a better sense of here's what happens in terms of staffing and all of those. But certainly I know there's an acute awareness of the need to help support physicians and administration sites in bridging that gap. And, we're all ears, as always. I think that policymakers are also looking for solutions, but part of it is hearing from the sites, the treating physicians, et cetera, as to what they need. And so I defer a little bit to Dr. Wiltz here, where he probably has a better sense of what the day-to-day, what you need, because you've done it and done it well, I think.
Well, part of it, I think, is introducing the vernacular on a national level. And in the beginning, as you know, and I'm sure Taylor knows this, we were not collecting data the way we should have as far as race and ethnicity. Even on the Centene study that I was on the panel earlier when we were doing testing, that was a challenge. And then I know in the state of Louisiana, the governor mandated that we would include that data so you can't manage what you can't measure. So we had to make sure if we were being intentional, what was the baseline. Every time I see the national statistics that keep getting put up and everyone speaks to it, these are the number of new cases, the number of people on ventilators, the number of deaths. If there was some space in that place that talked about, and people receiving the infusion, then it would be, we would get indoctrinated to saying, hey, I think at one point we were looking at how many people recovered from COVID as a statistic. Well, let's make an intentional space on the chart to talk about monoclonal antibody infusions. And then when the governor or whoever's when people are giving their press conferences, they need to continue to say that and talk about it to build the public consciousness of it. And then it's a campaign. It's a campaign like the other campaigns. So we've got to be able to do that. And then one of the first things that we did actually, because when I became aware of it, the monoclonal antibodies, then the referring orders that had to be written, there was the hospitals in New Orleans, the major hospital there, had already had developed the referral order sheet on what that looked like, and the criteria. And so we just adapted that form, if you will, and then got the process going. We figured out the workflow, what needs to happen and how to schedule the patients and get that done. And then we started getting more and more. We don't have a pure health information exchange system. We're working on it. It's not as robust and as it should be. But as to Dr. Birmingham's point earlier, time is of the essence. And if you get out that window, then that's tragic in and of itself. So timely information and reacting to it and knowing the logistics. But I think we need to have a more national conversation and start monitoring, measuring, and we can reach them. We can get to them. I describe what we do as marrying high tech with high touch. We know how to touch them. If you give us the technology, we'll get to them. We're doing remote patient monitoring devices. We're doing a whole lot of things right now that we didn't do before that are engaging people on a really much more meaningful way. It's one thing for you to come in my office every 3 months to get your blood pressure taken. It's something different if you're doing home blood pressure monitoring and I'm getting a log with your average, which is much more meaningful than just a one isolated reading, if that makes sense. So we're getting there. I think we can get there.
I do think we can get there. And I just want to take a second and thank you both for your contributions to this work, to the pandemic, and certainly thank you for spending the last hour talking with us all. I feel like I could spend the next 2 or 3 hours just talking with you and working through a plan of how to do this. But I do also believe that we can get there and really appreciate your contributions, your recommendations, and you also making sure that as you all are doing this work across your teams, that you're creating opportunities for others to partner with you in this, because it truly will take all of us. So thank you so much. And I turn it back to the organizers.